Good evening. Welcome, everyone. This is Lauren Lefebvre with Truth Medical. We appreciate you joining us this evening for our bi-monthly Lapiplasty Foundational Background and Philosophy webinar, where we will dive in to the foundation, the rationale, the clinical data and evidence we have, really just the why behind the development of the Lapiplasty procedure. A few housekeeping items if you haven't joined one of our webinars before. Upon joining, everyone is automatically placed upon mute, but we want these and really enjoy for these to be interactive. So we encourage you to type in any questions or comments in the questions tab found in the panel to the right of your screen. We'll keep an eye on these throughout, ask them as we go, and if there is any that we don't get to, we will absolutely have time at the end to tackle any of those questions and any additional that may come in. And now on to the main event. Our faculty for this evening is one of the key thought leaders in foot and ankle surgery, one of the founding design surgeons of the Lapiplasty system, going 10 years, over 10 years now, a true expert, having done over 1,000 cases, and who we fondly like to refer to as the godfather of triplanar bunion correction, Dr. Paul Dayton out of Ankeny, Iowa. Good evening, Dr. Dayton. How are you?
I'm great, Lauren. Thank you. And thanks everybody for hopping on tonight. Hopefully this will be interesting, or at least spark some conversation about bunion surgery, which has been one of my main focuses and main passions over the last 15 years. So this is the obligatory legal slide. I am a consultant for Treece. I've been honored to be able to work with their team for the last, well, over 10 years now, and not only in the research and development part, but also the medical education part. So tonight we're going to really just look back at why we think triplane correction and the Lapiplasty platform is not necessarily the newest, but maybe the most consistent and the most successful way that I have treated bunions in my career of almost 35 years now. We'll talk about the procedure steps and how we can achieve the goals that we aspire to every time we do a bunion procedure, and then talk about something that we're very proud of, is that we try not to just say it, we try to prove it, and we have a lot of clinical background from studies that we've published to show the success of this thought process of bunion correction. So I wanted to take just a minute and just focus on these x-rays. And what we're looking at obviously is a bunion and a bunion correction with the Lapiplasty triplane bunion correction system. But when you look at this, what you see is several things. Number one, we're able to correct the intermetatarsal angle, completely normalize the sesamoid position, normalize the hallux position, put the sagittal plane in normal functional alignment, and even correct the DMAA or the PASA, so the joint alignment. And we do this all through a very elegant and simple means at the TMT. And since the TMT is arguably the apex of the deformity, it's where the pathology begins, it's where the metatarsal deviates from, we can do this in a very minimally invasive manner through a relatively small incision with very little bone work. I mean, all I'm doing in this case is I'm taking two small slivers of bone off of both the cuneiform and the metatarsal, realigning, and then holding that joint in position, maintaining our correction. And the beauty of this in my practice is that I expect this in about 97% of our cases. And we've studied our cases, and there's been multicenter studies on this platform, and it's very consistent in that 97% correction. And when you really think about that, and you think of other procedures where we have to make multiple osteotomies, you know, several levels of the metatarsal or the hallux, or even do lesser metatarsal osteotomies, this really is a unique way to treat a bunion in a very minimally invasive way. And one further thing, and I'll talk about this as we go through, but our patients in our practice never see a cast. They are not on crutches. They're able to walk in a boot from the first day or two after surgery, and they're back in tennis shoes at 6 weeks. So when you think about that and you compare that to traditional bunion surgery and you compare it to the traditional Lapidus procedure, this really is a very new and a very innovative way to address bunions. And why do we feel like there needs to be a new or a different way to treat bunions? Well, you know, we argue about bunions so much. It seems like there's very little agreement on what the best means to treat a bunion is in the foot and ankle surgery community. Everybody seems to have their own way of doing it. And anytime you have a problem and there's a proposal for 130 or more different ways to treat the procedure, when we can't really agree on a basic philosophical approach to the procedure, it really means that we lack complete understanding of the problem. And for me, personally, where a better understanding of bunion surgery came in is when we started looking at it as a three-dimensional deformity. We stopped worrying about just these angles, the intermetatarsal angle and all of the other, two-dimensional things that we measure, and we really started looking at the problem holistically in 3 dimensions. And once we did that, everything changed. Our ability to get consistent correction changed. Our ability to really deliver for our patients changed dramatically. And I'm not going to belabor this because we all know this. You don't even need to read literature to understand that bunion surgery is inconsistent, at least from a traditional standpoint. You just talk to your patients, because all patients are scared to death of bunion surgery. And that's because they've had a neighbor or an aunt or an uncle or a sister that had bunion surgery and didn't go well. They had to have a second or a third or even a fourth operation. We see patients all the time. My practice, Mindy's in my practice, has developed or matured over the last 10 years to now about 85% of our surgical load is bunion surgery. And the sad part about that is about 25 to 30% of that is revision surgery from patients that have had less than desirable corrections. And you can look at these films and we've learned to accept the way these look over the years. I don't think any of these are anywhere close to an anatomic correction, and I don't even consider these recurrence. I hold myself to a higher standard, and some of these are my cases. I just think I didn't correct the problem to begin with. It's not that the bunion came back, it's just that this philosophy of two-dimensional correction with an osteotomy just simply doesn't treat the entire problem. And that's an important aspect of how we look at bunion surgery now. Again, we're trying to treat the entire deformity, and we know full well, and we see this in all of our practices, stiffness, pain following surgery, recurrence of the deformity, hallux varus, all of these things, unfortunately, are quite common. And again, I've come to the conclusion over the years that it's because we were missing something, and that something was we were not looking at the problem in 3 dimensions. And so the genesis of the Lapiplasty procedure, which was, it started actually prior to 2014, when the TREACE organization was forming. It started when Mindy and I said we're not going to do bunion surgery anymore because it's just so uncomfortable to not be able to deliver on a promise to a patient of correction when they're having all of these issues with recurrence and stiffness and all the things. And so when we started looking at the true anatomy of a bunion and realized that we were missing the 3rd plane or the frontal plane of the deformity, everything changed. So the genesis of Lapiplasty was simply to look at a bunion in a different way, look at it in 3 dimensions, and then figure out a way to consistently correct all 3 planes of the deformity. And we felt, well, if we can do this, then we're going to be able to achieve this result that we want for our patients. And at least currently, and over the last 10 years, that's been about a high 90% maintenance of correction and patient satisfaction. A couple of just anatomic facts is the normal first metatarsal is straight. With a bunion, the metatarsal is still straight, it's just deviated. And so when we're doing all of these multiple osteotomies, we're not actually restoring normal functional anatomy, we're actually making a new deformity. And I've talked about this for the last 15 or probably 16 or 17 years, and sometimes it gets uncomfortable, and surgeons get upset with me when I say that an osteotomy is making a new deformity. But when you just boil it down to basic deformity correction principles, that is the truth, because the metatarsal anatomically is straight. And this idea that we need 130 different ways to treat a bunion just really, again, shows our fundamental flaw in understanding of the problem. And then the one thing that we've talked about for years and years and years is this idea of hypermobility, which we don't believe that the TMT is hypermobile. We believe it's functionally unstable because of a genetic defect in the joint. And so we really can't say anymore, because there's a lot of literature and a lot of ideas to back up what I'm saying, is that you can't say that we're fusing a normal joint, because certainly the first TMT is not normal in a bunion. Otherwise, the patient would not get a bunion. It is a functionally unstable joint. And so bunions are not a metatarsal deformity. This is a normal foot. We all know what a normal foot and a normal first ray look like. This is a bunion, obviously, and that metatarsal anatomically is normal. It is deviated at the TMT, and the hallux and the sesamoids are deviated at the MTP, but the metatarsal itself is anatomically straight and is not, it doesn't have an inherent deformity. The deformity is at the TMT, or the deviation is at the TMT. And so we're taught to, see this as a problem that can be solved with an osteotomy in the metatarsal. And obviously this did not return that metatarsal to normal anatomy. And so we're also taught that there's different levels of bunions, different severity. So there's mild, there's moderate, and there's severe bunions, and that all of these should be treated in a different fashion. And that's what gets us to this, 100+ procedures, because we look at these three cases of a mild, moderate, and severe, and we can have an all-day argument if you have a room full of foot and ankle surgeons as to what procedures should be done for each. But I would argue, and I think it would be hard to have a debate against this, that these are all exactly the same problem. It's a straight first metatarsal deviated at the TMT. The hallux and the sesamoids are deviated at the MTP. And so in reality, we don't have different deformities. All bunions are not different. They really are all the same deformity. And that gets us back to this idea that, we have to get away from this idea that there's so many ways to treat a bunion. To me, there's, we need one method to just put that metatarsal, hallux, and sesamoids back into normal position. And this is kind of the backup for what I was saying about, we can't say that fusing the first TMT in a bunion is fusing a normal joint, because it is absolutely not. The first TMT and the vast majority of bunions is a unifacet, which is a very functionally unstable joint. When you look at normal feet, people without bunions, it's a trifacet or a bifacet, which is a much more stable construct, or a much more stable joint, which means that that metatarsal does not deviate from its normal position with normal weight bearing. And so if you think about that, and you think about this concept that, all bunions are really the same deformity of the metatarsal, sesamoids, and hallux, then it makes a lot of sense to attack it at the apex, which is the TMT, and it's also the site of functional instability. And honestly, I think those concepts, along with the fact that we treat all of these cases in 3 dimensions, is the reason why we've been able to have such a good success rate with correction, maintenance of correction, and also patient satisfaction, which is so important. And so sesamoid position really is what teaches us about the frontal plane component of a bunion. So we look at an AP X-ray, and it looks like the metatarsal is moved off of the sesamoids, and we measure the tibial sesamoid position. And in 2 dimensions, again, it gives you this feeling that the sesamoids are actually disassociated or subluxed from the metatarsal. And in our studies, Mindy and I have published several papers looking at the axial position, and even in patients on the AP that look like their sesamoid position is very, very abnormal, you can look at it axially and the sesamoids are actually where they should be, medial and lateral to the crista. They just look deviated because of this pronation of the first metatarsal. So if the first metatarsal everts and you have this 2-dimensional AP X-ray, it looks like the sesamoids are lateral when in fact they're right where they should be under the first metatarsal head, medial and lateral to the crista. Now, certainly there can be subluxation of the sesamoids. We see that all the time. We don't know the exact percentage. A couple of the studies that we published show that maybe up to 60% of the patients have no subluxation, and then there's gradation of other degrees of subluxation. There's been other studies. Kim's study was one of the first ones to look at that, and the one thing that they did find was that more than 80% of patients with bunions have a frontal plane pronation component to the deformity, and that's at the first metatarsal. Now, where the rotation occurs, we're not 100% sure. Some have suggested that it's torsion within the metatarsal. I believe from our research and our experience that the rotation is probably coming from the TMT, again, because it's functionally unstable. But understanding this kind of radiographic artifact of these sesamoids are not really disassociated in many cases really helps us understand what we need to do to correct it. And so if the first metatarsal is pronated in a bunion, to fully correct it, we have to supinate it. And so one of the first studies that we did was we got cadavers and we went to the fluoroscopy lab. We loosened up the first TMT and we put this pin in. We don't use a joystick pin anymore, but this joystick was born out of research to figure out what happens when you supinate and pronate the first ray. And so we put the first metatarsal through a range of motion of supination, which you see there, and pronation. And I mean, we almost fainted when we did this, because we could literally make a bunion or we could completely correct a bunion without doing any of the traditional things that we were taught to do. All we did was loosen up the TMT and put that metatarsal through a range of motion into supination, and we could correct every component of the bunion. And again, that's where the Lapiplasty system is born out of, is this idea that we can completely restore the functional alignment. And so if you contrast that to what we do with a traditional osteotomy, so this is one of my cases, this has got to be 20 years old because I haven't done an osteotomy for a bunion in close to 20 years. But you have a mild bunion. I did what I was taught, which was a Z osteotomy. I did my transverse plane correction. I did my lateral release and medial plication. I wrestled those sesamoids back underneath the head. And just like clockwork, and this was why I was so disappointed in my bunion corrections, it wasn't that I was doing the procedure wrong, it's that the procedure philosophically was not correcting the deformity. And what I would see is very early on, at a couple of months, the sesamoids appeared to be deviating again. I'm getting a widening of the IM angle. You can see at 4 years, the IM angle is bigger than it was to begin with. The hallux valgus is recurred. The joint is degenerating. And this comes from a study we did, a look back study. And I think it was 11-year average. And we had a group of patients come in, and what we did different in the study is we got sesamoid axials on all these patients. And we saw this in a high percentage of the patients. You see that axial there on the lower right. Those sesamoids have just drifted back medial and lateral to the crista where they belong. It's just that the first metatarsal is still pronated, and because I didn't correct it, because a sliding osteotomy doesn't correct frontal plane position. And this weight-bearing CT is not this patient, but this shows exactly what's happening with this traditional transverse plane, two-dimensional sliding osteotomy. To get the sesamoids to look normal on the AP X-ray, you have to actually dislocate them relative to the metatarsal head medially just to get them lined up in the X-ray beam. And this really is a very, very important point of, I think, why we see so many issues with traditional bunion surgery and why we need to address the frontal plane component. And this paper from Mortier is really excellent to look at the reasoning, the mechanical reasoning behind why that's so important. Because if that metatarsal head is pronated, all of the force vectors of the tendons, the extensors and the flexors, are going to give you an abnormal force on the hallux and sesamoids, right? So if that metatarsal is pronated, there's a net lateralizing force on the hallux and the sesamoids, which is going to give you a net medializing buckling force on the first metatarsal. And so when you really think about it, this is just my opinion and my thought, but this may be actually the initial reason we see a bunion. So the pathology is at the TMT. It's a functionally unstable joint. If it is pronated, then you have these net forces on the hallux and sesamoids pulling them lateral, and that's buckling the metatarsal medial. Maybe that's the genesis of how a bunion occurs. It makes a lot of sense when you look at all of the components that we understand better. And so by realigning the sesamoids, we're realigning those forces and making those forces a net zero to not be able to open up our IM angle or pull our hallux and our sesamoids laterally. And you can see this is, again, just a prototype case of what we're trying to do. So we're realigning in 3 planes. You can see I've realigned the frontal plane to the sesamoids back to neutral, which means they look perfectly normal on the AP X-ray in 2 dimensions, but we're looking in 3 dimensions now. We can see the axial. Hallux is normal, the joint alignment, the DMAA or PASA is normal, which you have to ask, how can that be possible if that's really a deformity or an adaptation of the articular surface? How can that joint look so perfectly aligned after we do a 3-plane correction? It would lead you to believe that that's actually just another artifact of the 2-dimensional X-ray. But this, again, is what we become accustomed to obtaining in high 90% of our cases with this philosophy. And just a couple of papers to prove that there really is some evidence to show that this idea that the articular surface is deviated or adapted may not actually be true. We've actually published 2 papers, and we're not the only ones. Others have published papers as well. And we showed in one study almost an 18-degree difference in the DMAA before and after. We didn't touch the big toe joint, and in the other study it was close to 15%. So what we expect, what we want to provide to surgeons is a platform that is reproducible, corrects all 3 planes, and corrects all of the components of the bunion at its apex, so at the TMT, at what I believe is the genesis of the problem, and then stabilize that joint so that hopefully we're going to have a very low recurrence rate. And we're in year 5 of our multi-center prospective study, and I think our recurrence rate is in the neighborhood of less than 2%. We'll look at some studies at the end, and I'll fact check myself on those numbers, but we want to get all of the components corrected. We want to keep that metatarsal in its normal anatomic state. And the most important thing, well, actually, that's all the things are important, so this isn't the most important thing, but a very important thing is doing this in a way that is relatively livable for the patient during the recovery. So traditional Lapidus, traditional TMT arthrodesis, and even modern lapidus or TMT arthrodesis is usually 6 to 8 weeks of non-weight bearing, many times in a cast, then transitioning to a cam boot for a few weeks, and then slowly getting back to shoes. So this is a terribly long and terribly arduous recovery for the traditional TMT fusion. You know, once you come out of a cast, you're stiff, you're weak, your calf is very, very atrophic, all of the things we see with non-weight bearing and non-activity. And so when we went down this path to design a system that you know, could correct it in 3 planes, one of the non-negotiables was we need to do this in a way where a patient can walk right after surgery throughout their recovery, and still provide excellent healing rates. And again, I'll talk about some literature and we can talk about that. And that's where this concept of biplanar fixation came in. And it's really just learning from and piggybacking off the external fixation world, where we have a multiplanar construct that can be smaller plates and smaller screws because they're at 90 degrees, extremely stable. And I let all of my patients walk within the first 3 or 4 days of their surgery, and 98% plus of our patients in our practice are back in a tennis shoe at 6 weeks. Which is vastly different than, again, the traditional TMT surgery. And I would say vastly different than many of the modern bunion operations, even some of the MIS operations. Yeah, this recovery is very, very efficient. And so the Lapiplasty procedure is different. I've talked about a lot of ways. Obviously, it's a 3-dimensional focus. We always are correcting in 3 dimensions. We use instrumentation. Any complicated orthopedic procedure is going to be more reliable if we have good instrumentation. And I can tell you, as somebody that did freehand 3-plane corrections for 3 or 4 years before we had this instrumentation, I will never go back to freehand. Could I do it? Yeah, I could probably get the job done. But you know, when you're doing, you know, a lot of bunion corrections, the consistency of having instrumentation that helps get the correction and then maintain the correction, I mean, you can't say enough about that. So again, we're very proud that we've been able to publish our results. We're very critical of our results. We're not just going to say this works and not be able to prove it to ourselves that it actually works well. One of the things is lesser metatarsal pain, which is very common with patients that have bunions, and it's also common after bunion surgery. The interesting thing about 3-plane correction, because we're restoring the entire functional alignment of the first ray, which means restoring the windlass mechanism, we're protecting the lesser rays, and we rarely, if ever, need to do a lesser metatarsal osteotomy, even if the patient has metatarsalgia before their bunion correction. In fact, in our Align 3D study, there was a fairly good percentage of our patients that had sub-second and third pain before surgery, and it was a very, very small percentage after surgery. I think the percentage before surgery was in the neighborhood of 14 or 15%, and after surgery it was 1 to 2%. So we are truly restoring the functional alignment, meaning we're restoring the function of the first ray. And the other thing that instrumentation allows us to do is be very consistent with our cuts. And we remove approximately 3 millimeters of bone, which, when you think about it and you understand the anatomy, is just simply removing the cartilage and subchondral bone. Everything else is maintained, which is less bone removal than most traditional lapidus procedures. And when you look at the osteotomy literature, it's even less shortening than many of the osteotomy procedures. So we're not going to go through this. I wish I had time, because this is very, very important and very interesting, very exciting to me. But we don't use angles to decide how we treat our patients with bunions anymore. It's completely an anatomic algorithm now. So the first decision point is there arthritis at the big toe joint or not? If there's arthritis in the big toe joint, I'm not doing a TMT correction. I'm doing a MTP arthrodesis, in some cases a double. And then the second decision point is there metatarsus adductus? Because if there's metatarsus adductus, there's essentially no bunion procedure that can reliably and consistently correct the bunion. So if there's metatarsus adductus, we have to recognize it. We have to realize that that is part of the overall foot deformity, and we have to correct that. And we've been working on solutions, systems, instrumentation for all of these classifications within this anatomic class of bunion surgery. We actually published a paper on this concept back, I think it was in 2018. It's literally changed my life, not having to, worry about it, whether the IM angle is 15 or 18 or 13, and trying to make all of these decisions based on angles, when in fact, we just need to put everything back where it should be, regardless of the angles. So we're going to go pretty high level, just through some of the key points of the procedure itself. So the procedure itself, it's interesting because you think of a osteotomy procedure, as the osteotomy producing the correction. But where Lapiplasty is different, and why I think it is extremely powerful, is because we actually correct the deformity before we make the cuts. And if you think about that, that's pretty powerful. Number one, I know where that metatarsal sesamoids and hallux are going to be every time after my cuts because I've corrected it before. And number two, because we've corrected before we cut, the cuts are always the same. So we only need one cut guide, because all we have to do is make sure that we maintain the first metatarsal parallel to the second. And once we correct the deformity, that's made by just making a cut in the cuneiform perpendicular to the second metatarsal, and a cut in the first metatarsal perpendicular to the first metatarsal itself. That gives you a net IM angle of 0. So the cut is the same every time. And there's a lot of comfort in that, actually, because we don't have to eyeball and freehand the cuts anymore. We correct, then we cut, and then once we take the fragments out and prepare the surfaces, we just dock those two surfaces. And something that I will never get away from, I probably don't have that many more years in my career. I'm at 35 or 36, I guess 36 now, since it's 2026, is this idea of biplanar plating. I have never seen healing as fast and recoveries that are as easy as what we see for our patients. Again, our patients are all walking within the first few days of their surgery, and they're back in a tennis shoe around 6 weeks. Full activity, including high impact sports, is not till 4 months, but there is no bone procedure that should be allowed to be stressed with high impact sports before that time, because that's just how bone heals. So this is a typical case. I think we've done 1, 2, 3, 4, or 5 Treese cases this week, and this is how they go every time. We loosen up the TMT, we do a MTP release. In most cases, we do it laterally now. I used to do it medially, and we put the fulcrum and the positioner on, and we literally just dial the bunion away. And again, as a foot and ankle surgeon, this is very comforting, because once I get it dialed in, I know where I'm going to end up at the end of the case. And you can see this same patient, we're going through the correction mechanism, and I know that I'm going to be able to obtain that at the end of the procedure. From here, it's a very simple process of cuts, remove bone, prepare surfaces, fixate, and we're done. So we do that through what looks like very simple instrumentation. Took a long time and a lot of trials and a lot of research and development funds to get to this point. But this instrument, the fulcrum and the positioner, because they allow independent movement of all 3 planes at the same time, we're able to do this seamless correction. I personally use the internal positioner. I think it's much more powerful. The external positioner is there. Some people are using it. I'm much more adept and comfortable with the internal. So just quickly, We do this through a what is termed a minimally invasive approach. It's an incision, obviously, a relatively small incision when you compare this to the traditional Lapidus or a lot of the osteotomy procedures. It's minimally invasive because of the way we treat our tissues. So minimal incision and minimally invasive are two different concepts. So you can have minimal incision and have a very invasive procedure, and you can also have an incision and have a very minimally invasive procedure. So we do full thickness dissection, so we preserve all of the blood supply from the skin to the bone and periosteum, because the blood supply to the periosteum comes from the soft tissue side, not the bone side. So we do subperiosteal dissection. We expose the TMT, very simple and streamlined. We plane the surface, which is the first step of loosening up the TMT, because we want to get off the uneven surfaces. So very simple planing step. Saw goes in halfway down. We do a couple of zips down. We're taking off that planar flare and the uneven medial surface that allows two congruent surfaces. There's always some ligaments over on the lateral side. We take a sharp osteotome, and we have proprietary instruments for this that are much sharper than any of your hospital's osteotomes, so they work great. But we do the final release, and then we're going to put the cut guide in, and the cut guide consists of 3 components, and those components originally were separate. So we had a joint seeker. That joint seeker sets our sagittal plane cut, so we don't erroneously elevate or planar flex the metatarsal. We put in a fulcrum, which is a pivot point. That's where we get our angular IM correction, and then a cut guide. And so it's evolved over the years, and that's one of the unique things about Treece, is that we continue to iterate the instrumentation solutions. We continue to iterate the procedure. We continue to be very critical of our results and learn from them and get better over time. And so the second iteration was combining the seeker and the fulcrum, and that very, very quickly led to what we have now, which is the 3-in-1, combining the cut guide, the seeker, and the fulcrum. But it is still extremely important to understand what each of these components do, because obviously we're operating on patients. No 2 patients are exactly the same. So there's going to be situations that, things may not roll through the steps of the procedure the way they should, and understanding what each of these components do is extremely, extremely important to be able to get consistent outcomes. So I always like to point out what each one of these components is giving us. So early on, way back in the day when we did freehand correction, we used to talk about it and say that you don't need to do a lateral release at the MTP. And I'm here to tell you I was 100% wrong with that. Corrections are much better, and we recommend in nearly all cases now release of the accessory suspensory ligament of the sesamoid and the lateral capsule. It's extremely important to be able to get full correction. This is the proof of that. This is one of my cases. You can see the positioner on in the fulcrum, and I try to do the correction maneuver, and that is not rotating. You do not see the sesamoids going back into position. It is getting bound up and jammed because I have lateral ankylosis. And so this is simply the exact same setup, but now you can see that I'm getting robust rotation because I've done this lateral release. You can even see the hallux coming back into position. Everything is working exactly as it should. We're right where we want to be. And so since this was so important, and the surgeon design team, we met many times on this and did lots of dissections and challenged ourselves to get a good release through a small incision. And honestly, none of us could do it. So we developed this instrumentation, the speed release, to be able to do a very comprehensive lateral release through the small incision. It's really been a game changer. I used to do my my lateral release through a medial approach, which works great, but it's a lot more dissection, a lot more work. This is like a 2-minute maneuver, small incision, lateral capsulotomy, pop in the tip, the probe, which follows the tissue, and then the cutting edge cuts as it goes through. And this goes, one of our biggest problems in the early days when we were doing freehand releases was this is much more proximal than anybody thought it was. So you can see we got a great release just with a very simple approach. This is after just a little stab incision, lateral capsulotomy. We wiggle this back and boom, all the way back. I usually do an adductor release, which means I just flip my hand over and I run the same instrument down the base of the lateral base of the phalanx of the hallux, and I get my adductor, and I even sometimes do the deep transverse ligament. It allows much more freedom, but super simple. So at that point, we put on the 3-in-1 that we talked about. We have our positioner. Our fulcrum is integral to the cut guide. Our seeker is integral to the cut guide so that our sagittal plane is going to be lined up correctly. And incidentally, if you use the internal positioner, and I'll show you putting it on here, but if you use the internal positioner through this same standard incision, it actually plantar flexes the metatarsal as you're going through the maneuver. So you don't need to grab the hallux or push on it or do anything at all. It literally is correcting, and in our cases, it's correcting all 3 planes at the same time. That's why I love the internal. Most people can't kind of see in their mind's eye how this works. This is how it works. So the medial ridge of the metatarsal where the cup goes is plantar when the metatarsal is pronated, right? So it's plantar from the midline of the foot. And so the positioner goes on at a pretty severe angle from plantar medial to dorsal lateral. And then as you turn the guide and you're reducing the IM angle, which, you know, everybody understands that, that's intuitive, but we're also inverting the metatarsal or supinating the metatarsal. And it just so happens if you have it set up in this manner, it's also plantar flexing the metatarsal. So now I have a completely anatomic correction right where I want to be. And so we made our cuts, we get our bone fragments out, we have instruments to be able to help do that. It's one of the more frustrating parts of the traditional Lapidus is getting the bone fragments out, but we have instruments that help be able to get those fragments out. There's a hooked osteotome. Then we fenestrate the surfaces. I usually put 5 or 6 holes in each side. I don't want to put a huge amount of holes in the bone because we need to fixate it. And if I'm removing all of that internal bone, my fixation components are not going to be as sturdy. But we irrigate, fenestrate, take the pieces out. With the instrumentation and the way we do the releases before, many times the pieces come out, all at the same time, like you saw there. Then we have to dock the surfaces. There's different ways to do this. This is what is the kind of the current compression device. There's been multiple iterations. I'm now using the adductoplasty compressor from a lateral approach on this, like we do with adductoplasty. But this is kind of the standard technique. We dock the surfaces, then we get provisional fixation, 2 points. You can use the threaded olive wires, or you can use smooth wires, but we have to have 2 points of fixation. The reason I use the adductoplasty compressor now from lateral is I don't need that lateral wire. I use, just like we do the adductoplasty compressor on the 3rd TMT, I use it on the lateral side. That way I don't need the wire. Everything's docked. I just put a medial wire, and then I can plate with the compressor on, which is hard to do with the current compressor. But there's all kinds of, just spoiler alert, there's all kinds of design iterations happening as we speak, with some new ways to streamline the procedure, make all of the steps easier and more reliable. So again, I think I alluded to it earlier. I'm not going to, I don't think in the rest of my career ever do any small bone surgery, especially fusions, without a multiplanar construct. I was using biplanar plating for 7 or 8 years before we designed the system for Lapiplasty. Done thousands of cases. I just have a huge comfort level with the healing. And the reason is because I spent a lot of time trying to understand external fixation and bone healing and how that all interacts. And so multiplanar fixation without highly compressed surfaces is a totally different animal. It heals by callus healing, which is faster, it's more biologic. All of the things. We don't need to belabor this, but this is all the new AO research in the last 20 years looking at this concept of relative stability and fostering callus healing, which is the most natural type of healing. That's what we're capitalizing on with this idea of biplanar plating. And we have lots of different options to choose from in the plating as far as anatomic shapes, straight plates. We have revision plates that are longer if you have to have a graft. And then the newest iteration, which is the speed plate, which, by the way, is not a staple. Nobody can call this a staple. This is actually functioning in a equivalent manner to our titanium plates. It's the same materials, the same design concept, the same biplanar construct. It's how it differs is just in the insertion technique, which is more like a staple, but the function is meant to be like a plate. So again, you have this concept of a little bit of dynamic movement of the plate after it's inserted to be able to hold the surfaces together. But most importantly, we're using this in a biplanar construct. We've iterated the screw technology to give you the best locking screws with faster pitch screws, which actually act to allow the plate to actually do a far cortical compression. This is the concept that I use in my cases because I'm mostly doing the traditional plates, but because the screws are actually compressing the plate or causing a little bit of preload on the plate, that is actually induced across the bone to give you far cortical compression. And this is a very powerful concept if you think about it. When you put the dorsal plate on, if you use this concept, that far cortical compression is reinforcing the plantar flexion, and then when you put the medial plate on, the far cortical compression is reinforcing your IM correction. So again, a very elegant way to use your plates to help you with your overall fixation, not only, but also healing. And so this is just a case that I threw in that I think is pretty representative of Lapiplasty, at least Lapiplasty in our practice. You know, it's a moderate to moderately severe bunion. This is rotation and subluxation, and you can see this is a 1-year post-op. You can see that we're able to normalize all of the components of the bunion, maintain it, have a well-healed tarsal metatarsal joint arthrodesis. This patient followed our normal postoperative protocol, was a bandage for 3 days, transitioned to a cam boot. This is my personal practice protocol that I'm talking about now. So a cam boot at 3 days, they're able to shower at 3 days. There's no bandage, no splint. They start range of motion at that time and they walk 10 minutes per hour in their boot. Matter of fact, we tell them, we want you, not just you can, we want you to walk 10 minutes per hour because that helps with swelling, desensitization, maintenance of muscle, range of motion, all of the things. They also do not sleep or have their cam boot on when they're sitting. So cam boot's off for sleeping, it's off when they're sitting. We want them moving their foot. This is the same lady, super nice, mid-40s lady. This was at 1 week post-op. You can see minimal swelling, incisions look great, and that's all because we're doing this not minimal incision. That's just about what you see from the outside. We're doing this minimally invasively. That's what's most important. That's what we're doing inside. So we're doing minimal soft tissue disruption. We're doing actually extremely small amount of bone work. We're just taking those 2 slivers out. So there's very little bone work. And then we have this very stable construct. So this is a very, I would call it an average result at a week after our personal technique of doing the Lapiplasty procedure. And so this is the sanitized version. If anybody has more questions about our personal perioperative optimization, I can absolutely get you lots of information. Obviously, surgery is not just the surgery, it's what we do before surgery, what we do during surgery, and then what we do after surgery, and all of it matters. And It's just my personal feeling that immobilizing a patient is maybe the worst thing we can do for extremity surgery. I think that's becoming more and more widespread in realization across the foot and ankle community. So studies, we're not going to go into them in detail, but we have lots of information looking at all components of this concept of three-dimensional correction, from healing to correction to patient-reported outcomes, and long-term results. Again, we're in year 5 of a prospective multicenter study. This was a interim report, a 48-month report that was presented at AOFAS this year. Pretty remarkable results when you think about the traditional, Lapidus procedure and even a lot of the traditional bunion surgery. So return to weight bearing at 8.4 days, recurrence rate of less than 1%. If you look at the hallux valgus at 20 degrees and about 7.7% if it's hallux valgus at 15, which is, I think, a more fair way to report recurrence. So many studies reported at 20 degrees, which is really the definition of a bunion, but that's beside the point for this. We're reporting it at what I think is a very a fair way of looking at recurrence. Very low non-union rate. The traditional Lapidus procedure has anywhere between a 5 and 15% non-union rate. Again, we're treating this joint a lot differently, the way we dissect it, the way we prepare it, and absolutely the way we fixate it. And then very, very important are the patient-reported outcomes, pain improvement, improvement of all of the functional and social aspects. And it's interesting when they look at it over the 4 years, the improvements were very early in the recovery and they were maintained to this point of 48 months. And next year we will have all of our data collection complete. So we will have the complete 5-year results. So happy to answer any questions. I threw in a couple more correction videos. This is a case from, I think, last week or the week before. It's still, after 1,000 cases and all these years, to me, it's just magical to watch this correction occur, and it's so fun to actually see the patients back in the office and actually be able to, really tell them I delivered on what I told you I was going to deliver on, which I really never did a very good job of with the old 2-dimensional techniques.
Thank you, Dr. Dayton. This was outstanding. A couple of things initially. Getting preoperative axial x-rays, can you talk about the importance of that and maybe go into the why a little bit on why you like to get those?
So we get preoperative axials on all patients and postoperative axials on all patients after their 6-week x-ray. It's hard for people to get an axial up to the 6-week point, but after that we get them. That's how we know that we got full correction. So that the post-op one is important to know we got full correction. So preoperatively, it's important for several reasons. So number one is we know whether it's pure rotation or rotation and subluxation. Rotation with subluxation is a little bit tougher to correct. You need to have a little bit more attention to detail to your releases. You may need to do a little bit more work to get things to move back into position. The other reason is I don't want to operate on a patient that has significant arthritis in their big toe joint and not address the arthritis. And the sesamoid metatarsal articulation, at least from what we have learned so far, is a very sensitive way to determine whether there's significant arthritis. And so if there's significant arthritis at the big toe joint, we're doing a triplane MTP arthrodesis. And that's a high percentage of our cases. So the axial is very helpful with that as well. And the other thing is just getting used to looking at the difference between the sesamoid position on the AP and the sesamoid position on the axial, and understanding what they both mean and how they interact with each other. Like I was talking about early in the talk, that we look at the AP X-ray and it looks like the sesamoids are subluxed from the metatarsal, and really they're right where they should be, and that really teaches you, it reinforces this concept of how important it is to supinate that metatarsal to get everything back into position.
Excellent, thank you. And then in terms of weight bearing, do you ever use a postoperative shoe?
We don't. There are surgeons that are using post-op shoes in their postoperative recovery. We find that, we're aggressive with our recovery, but we don't want our patients to feel like they can literally do everything. Again, it's 10 minutes per hour for that first 6 weeks. That seems to be the sweet spot. It's super safe. A shoe kind of gives them, I think it gives them a feeling of maybe too much freedom, and that's just my opinion. It's probably perfectly safe. We used to do all of our first MTP fusions in a post-op shoe, and healing rates are great. We've kind of reverted back to the cam boot just to, again, remind the patient they have to, they had surgery, they have to protect it. But the boot in our practice is not on for sitting or sleeping. We want them to be able to move their foot normally and regain their range of motion. It's super helpful with swelling and even with pain and desensitization to be able to move your foot. The worst thing for pain is immobilization.
So do you do PT, postoperative PT?
We do, in some patients. It's not universal. Since we're having them walk from very early on, and they're not, they're only in the boot for short periods of time during the day, they're able to move. Most people, by the time they get back to their tennis shoe, they bounce back really quickly. If they're hesitant to get on their foot, or if they're not progressing through, then yeah, absolutely, we do physical therapy, but it's not universal in our practice. If I had to guess a percentage, I would say it might be 10 or 15% of the time that I send somebody for formal physical therapy. There's so much power in that early activity.
Perfect. So far, that's everything that's come in. Thank you, everyone that's been in attendance this evening. Dr. Dayton, thank you. Love doing this as always.
Yes, absolutely.
I would like to also plug, you guys do a significant amount of peer-to-peer interactions throughout the week, daily, weekly, monthly. If you have a case that you would like our design surgeon input on preoperatively, you have something postoperatively you want to discuss, you want to plan out a case, you guys do this very regularly. Please reach out to your local representative, the medical education team, the product management team at Trees. Dr. Dayton, any insight, you can provide it all there.
We love those. We love nothing more than talking through cases. If there's issues or problems, it's probably happened to us many times, and we've seen it, and we've been there, and we have workarounds and fixes for so many things. So yeah, we love to interact with surgeons to help everybody get the best results they can, help them be comfortable with the instrumentation. One of the most powerful things that Trees has invested in, and it's a big investment to provide that to surgeons. And then we didn't talk about it. We'll probably get in trouble, Lauren, but the education at Trees is, I mean, honestly, and I'm a consultant, so obviously I'm biased, but this is what I do. This is all I do from a bunion surgery standpoint. I did this before Trees existed, and I'm not going to stop doing it. And I would say our education is some of the best in the country. I mean, if you go to one of our labs symposiums, it's honest, straightforward. It's not just a marketing boondoggle. It's true education, and all of the faculty is super passionate. They're not trying to sell you anything. They're trying to show you what we have learned over the years. So yeah, the trees education is pretty darn spectacular.
I agree. So that being said, we have a number of medical education events throughout the year, local, regional programs. Once again, please reach out to your local representative, the medical education team, the product management team, and we are happy to facilitate every single thing you could absolutely ask for. These are our favorite things to do: interact one-on-one with, connect you with your peers. Dr. Dayton, thank you, and I appreciate you being here.
Thank you, Lauren, and thank you everybody for being on. If any questions, please reach out to Lauren and she'll get them to me.
Absolutely. Have a great night, everyone. Thanks so much.
Good night.